Good afternoon to all of you on the East Coast, and good morning to all of you on the West Coast, and thank you for joining us for today's webinar. My name is Dr. Jose Leon, and I am the Clinical Quality Manager for the National Center for Health and the Aging here at North American Management. I am very pleased to introduce our selected panelists for today's webinar entitled Alzheimer's, Providing Knowledge and Care. Our presenters for today's webinar are Dr. Henry Pacheco. Dr. Pacheco has many years of experience working in public health. Dr. Pacheco has worked on program development, technical assistance, and management with a particular focus on prevention and healthcare delivery for the Hispanic population in the country. Dr. Pacheco served as Director of the Center for Health Promotion at the National Council of La Raza, and he has worked as a private consultant in various health research and training projects in Latin America with the Pan American Health Organization. Currently, Dr. Pacheco is the Medical Director at the National Hispanic Council on Aging. Our second presenter will be Dr. Sofia Georigiadou. She is originally from Thessaloniki, Greece, and Sofia is specializing in systemic family therapy approaches and has completed a 5-module training in Hellinger's family constellation work. She is currently working full-time as a behavioral health services provider at Houston Area Community Services in Houston, where she conducts group and individual therapy with a diverse clientele consisting of young adults, homeless, low-income residents of Houston, HIV-positive patients, and LGBT individuals. Next, we will have Dr. Jane Tilley. Dr. Tilley joined the Administration on Aging in December 28 as Team Leader for Dementia and Brain Health Programs. She has extensive experience with research and policy analysis on a variety of health, long-term services and supports, and public benefit issues at the state, national, and international levels stemming from her work at the Urban Institute and AARP Public Policy Institute. Just prior to joining the Administration on Aging, she worked on dementia policy and practice issues for the Alzheimer's Association. Our distinguished panelists will focus on the different types of dementia. They will talk about the importance of caring for family members and patients diagnosed with Alzheimer's disease. They will discuss the difference between normal age-related memory loss and Alzheimer's disease. They will examine the strategies for preventing and managing challenging behaviors and communicating with individuals with dementia. And they will focus on the responsibilities and limitations caregivers have toward their patients and family members. And they will also share tools and resources available to assist patients with dementia. I would like to mention that at the end of the presentation, they will take any questions and address any issues that you may have. Teresa Brannan, our Training and Technical Assistant Manager here at the National Center for Health and the Aging, will facilitate the Q&A portion of this webinar. Without further ado, I would like to turn it over to Dr. Pacheco. Good afternoon, Dr. Pacheco.
Great. Thank you so much, Dr. Leon. I appreciate it. Well, first of all, good morning, and thank you so much for attending this webinar. As I mentioned, my topic will be an overview of Alzheimer's and other dementias, and I present there my learning objectives. After my presentation, Dr. Georigiadou and Dr. Tilley will give you also a very good, very nice supportive presentations that will deal much more on issues regarding support and resources for people with Alzheimer's and other dementias. Let me just start by discussing what is dementia. Dementia is essentially a general term. It's not a specific disease. It's an overall term that describes a wide range of symptoms, which are associated with a decline in memory and other thinking skills. And it's characteristic because it's severe enough to reduce a person's ability to carry out, perform everyday activities. it really describes a collection of symptoms caused by many disorders that affect the brain, and some of them will explore them as we explore, in particular, Alzheimer's. Types of dementia, there are several types of dementia. Here we've mentioned a few of them. Alzheimer's disease being where we are focusing, and what is really about 60 to 80% of all dementias. And then comes vascular dementia, 10 to 20% dementia caused by micro strokes and just vascular damage to blood vessels feeding the brain. Then there's dementia with Lewy bodies, about 5 to 10%, mixed dementia, Parkinson's disease, frontotemporal level dementia, Creutzfeldt-Jacobs disease caused by slow viruses, prions, it's been in the news, associated with mad cow disease, and normal pressure hydrocephalus. This is just some of the many dementias. As I said, our focus will be on Alzheimer's disease. Now, what is Alzheimer's disease? Well, the characteristics is that it is a irreversible, progressive, and fatal neurodegenerative brain disease. So that's more or less how it should be defined. What are the characteristics? Loss of memory, which means an inability to learn new and recall old information. And of course, there's also decline of one or more of the following capacities. Decline or loss of language, a slow degeneration in the ability to manage language. Decline, a gradual decline in purposeful action. Recognition of people, recognition of objects, recognition of family. And also a loss of what is called executive function. The ability to exercise good judgment, the ability to think abstractly. And of course, all of these, the characteristic of all of this put together is that it interferes with our social and occupational and daily lives. And so that is the characteristic of Alzheimer's disease. Just briefly, the impact of Alzheimer's disease in our population is significant, and it's growing. Right now we have about 5.4 million people in the U.S. that have Alzheimer's disease. With this growth, for example, projected to grow up to 11 to 16 million by 2050 if there's no effective treatment for Alzheimer's disease. And currently there's over 24 million people with Alzheimer's disease. Now, one of the things that I wanted to mention is that, first of all, we talk about significantly about the improvements that we have made in mortality due to cardiovascular diseases and cancers. Nevertheless, mortality secondary to Alzheimer's disease has increased 20% in the past decade. And it's also a tremendously expensive disease to take care of now. We have, it's over 200 billion in all costs associated with the care of people with Alzheimer's. Now, the graph that I have on the right-hand side shows you that since Alzheimer's is very closely linked with aging, it shows you that we have significant issues ahead of us, because as you can see from the graph, the population aged 65 and over, and definitely the older population, the 75 to 85 and over, is expected to grow significantly in the next few decades. So that should more or less give you an idea of how we expect Alzheimer's to grow. Well, what is normal age-related cognitive decline? As we get older, we all experience a decrease in the rate of how we process information. Things slow down a little bit, especially as it's called nonverbal information. Sometimes you have problems recalling a name, recalling a location. There's some decrease, a small decrease in executive skills, but you can still learn new information, and you can still, and none of these are progressive, and none of them interfere significantly in the quality of life of the person as they get older. And so that is the normal decline expected, I guess, in some ways, from the aging of the brain. Now, there's several challenges to the clinician, and this is to whom this is of course directed to clinicians. First of all is, to be able to distinguish normal age-related cognitive decline, and also to distinguish Alzheimer's and irreversible degenerative disease from other potential causes of cognitive impairment, things that can mimic Alzheimer's and things that need to be ruled out, because some of them are preventable and some of them are correctable. And here's a listing. For example, we do know that chronic alcohol abuse, drug abuse can lead to symptoms that very much mimic dementia. Obviously, subdural hematoma, obviously the existence of tumors, and of course these are all potentially correctable. Detection of tumor can lead to extraction and significant correction. Same thing, normal pressure hydrocephalus. There can be some, a shunting in the ventricle can relieve that, and you can regain a great deal of the loss of cognitive impairment. Other things, metabolic disorders, hypothyroidism, very easily detectable, and yet if it goes unrecognized, it can mimic some of the signs and symptoms of dementia. Let's not forget the medication, the side effects of certain medications that are used for anxiety, medications, some antihistamines. All of this, particularly in the older patient, can cause can lead a physician to think that this person may be having some dementia. Likewise, the interaction of medications. Depression, by the way, a significant depression is it can also mimic Alzheimer's and dementia, and to complicate things more, Alzheimer's is very much associated, depression is very much associated with Alzheimer's. There's, of course, psychotic disorders, HIV dementia that needs to be ruled out, Lyme's disease, syphilis, both put together, both caused by a spirochete, both potentially treatable, well, with antibiotics, and yet Lyme's disease, syphilis, when it invades the neurosystem, it can cause some of the very similar symptoms of dementia. Likewise, hepatic uremic encephalopathy, and strangely enough, low literacy or language impairment. In some cases, people that had language issues, did not speak the language or had some literacy problems were actually suspected of having some issues with cognitive impairment. So those are the things that the primary care physician, of course, has to be very alert, because many of these are very correctable, and they can, and once treated, the person can go back to his or her normal state of being. So it's important to keep this in mind. Now, let me, this thing is not advancing. Let me just click in here. And now let me focus our talk on Alzheimer's disease, the most common form of dementia. Some of the risk factors, of course, is associated with old age. As we get older, the incidence doubles practically every 5 years after the age of 65. It's associated with some family history of Alzheimer's disease. It affects mostly female, and it's also associated somewhat to lower educational levels. There are some genetic risk factors, some mutations in 3 genes associated with Alzheimer's disease, same thing with apolipoprotein. So there are some genetic risk factors associated with Alzheimer's disease. Pathophysiology, how does it how does this disease affect? Well, we know basically, and this will be only a surface discussion of this topic, that the basics is that there's a disorder of amyloid metabolism leading to formation of plaques, actually, amyloid plaques in between the neurons. Now, it is believed that some of these things occur in the brain long before even symptoms have actually manifested. So some of this is already taking place, and yet symptoms are still not manifesting very obviously on the patient. Then you also have the neurofibrillary tangles, which are tau proteins that are actually should be well organized within the axon of the nervous system, and then they come out, they become tangled, and so what you have is a loss of synapse, neuronal, which are nervous cells of the nervous system, the neurons. There is inflammation, then there's death. Associated with that, of course, is the loss of neurotransmitters, which essentially leads to that a gradual, degenerative, and irreversible, to some extent, cognitive impairment. The loss of neurons, of course, leads to abnormalities in multiple regions of the brain. So there's a neurodegeneration that, when it's in advanced stages, can actually be seen by a CAT scan or an MRI. I'm not going to go too much, but there's just a picture of how the normal transmission axonal workings in the brain, all of this is disrupted by Alzheimer's disease, some of the symptoms of Alzheimer's. Early, in the first 2-4 years or so, you have some mild cognitive impairment, somewhere between the normal forgetfulness of aging, and of course the development of Alzheimer's disease. Very challenging for the primary care provider to actually elicit this and realize that this might just be at the beginning of Alzheimer's or just some mild cognitive impairment. Then, of course, it moves to a more moderate phase where it becomes almost obvious that this person is suffering from Alzheimer's. You have changes in sleep patterns, depression, agitation. Then, the difficulties with simple tasks, dressing, reading, writing. The words just are not coming through. Driving, a very big problem. Many times they will drive, and then in the middle of somewhere they'll feel completely lost, even though they are in a route that they've traveled so many times. So driving becomes a significant issue, and in fact, there are many states that have laws that somehow regulate driving among people with Alzheimer's. And of course, then later the patient develops some aggressive behavior, shows signs of very poor judgment, becomes very argumentative. There's a degeneration in capacity of language, mispronouncing, some confusing sentences. And then gradually, because of all these problems and the disease, you see a significant withdrawing from social contact. The patient begins to withdraw into himself. And then, of course, in the more advanced stages, the person fails to understand conversations, doesn't recognize family members, and definitely cannot perform basic activities. By this time, this person is incapacitated, probably bedridden. Incontinence, fecal incontinence, urinary incontinence leads them to have to use diapers, be changed, and essentially this person by now and probably even earlier needs practically 24-hour care, or at least supervision, to make sure that they don't harm themselves or others. And of course, Alzheimer's leads to death, usually from infections, pneumonias. As I said, these folks have problems swallowing, and all of these things will lead to eventual death. And of course, there are many other deaths caused by accidents that happens to them, falls, and just errors in judgment. I will concentrate on the diagnosis of Alzheimer's disease, directed, of course, to the primary care provider. Very important, of course, to take a very good medical history to elicit changes in deficits, the rate of progression of these deficits. Of course, very important in during this examination, not only to have the patient, but a close family member that can corroborate these things. And of course, depending on what stages, early in the stages, some patients will actually recognize this. Others will try to hide this or are embarrassed to admit some of this. But a good medical history, are there changes in behavior? Are there changes in gait, any movement issues? Family history, as we said, very important in Alzheimer's. Is there any past history or any family history of dementia, of Alzheimer's? Past medical history, important. You need to know the patient has suffered from or suffers from hypertension, has had strokes, diabetes. All these things are very important to start getting the picture to what degree is this a degenerative Alzheimer's, or is this something that can be prevented or at least improved by strict control, good control of these things like diabetes, hypertension. Also, employment history. Has there been exposure to toxic materials, toxic metals? Any history, psychiatric history, and history of substance abuse that can be reflecting on these deficits for which the patient has come to your office. Laboratory, many of them are routine, but many of these laboratory exams should also be are a very useful tool to rule out treatable medical conditions that might be responsible for these cognitive deficits. As I mentioned, in a previous slide, some of those things that can mimic Alzheimer's. So you need hematocrit, be sure there's no anemia, thyroid-stimulating hormone, TSH, to be sure that there's no hypothyroidism present. You want to do, of course, electrolytes, make sure there's no hyponatremia, fasting glucose, vitamin B12 levels, folate deficiency. You want to do an RPR to rule out any syphilis that has gone unrecognized, and it could be neurosyphilis, giving the symptoms of deficit in cognitive deficits. Erythrocyte sedimentation rate, and definitely an HIV test to make sure that that has not gone unnoticed. In future tests, there's current research. There's always that looking for specific biomarkers for Alzheimer's disease. Some of them are being identified, and I'm sure eventually in the next few years they will make it slowly and surely into our routine medical practice. cerebrospinal fluid analysis from spinal tap to see if there's the presence of biomarkers that can definitely diagnose Alzheimer's. That's in the makings in future research, or blood or urine samples. Physical exam, of course, a thorough neurological exam to detect any sensory deficits, any neuropathies, any abnormalities in gait, mental status assessment, obviously, and of course any other comorbidities. The primary care physician who has had, who have had experience with Alzheimer's patients, dementia patients, of course, are already pretty handy and really know well the use of neuropsychological testing, things like Montreal Cognitive Assessment, mini mental exam, the traditional clock drawing test. These are tests that, if you're going to be treating Alzheimer's patients, you become familiar and comfortable with, and that'll give you, a pretty good assessment of where this person's mental status is, cognitive status. Other routine tests, they may not be routine, and they're still controversial to what degree should the primary care provider use them. Well, the CT scan, of course, I can tell you already there are some degenerative changes in the brain, in the presence of tumors and presence of other abnormalities, obviously hydrocephalus and all that. Then there are other tests like the MRI, the PET scan, which, I'm not sure I was going to call them routine or not. They probably should be led by a neurologist. Cerebrospinal fluid analysis, that's fairly routine for the primary care provider to essentially, as I said, not necessary to detect any biomarkers yet, but to be sure that there are no other conditions there that might be inflammatory, infectious, or conditions that might explain this status of dementia of the patient. And of course, referrals, consultations, once you've determined that there is some degree of dementia, Alzheimer's, possibly to a neurologist, and definitely to social and support services, referrals not only for the patient, but for the family, for the caregiver. And of course, your differential diagnosis should include treatable conditions, so we mentioned before, that need to be distinguished. And also, care has to be placed to be sure that that you're not dealing with a dementia like Lewy body or frontal temporal lobe dementia, because some of the medications that are traditionally used for Alzheimer's can have important negative effects on them. So you have to be sure you pin down this dementia. Importance of early diagnosis. Of course, it is important because this is going to have a tremendous effect in the next few years on the life of the actual Alzheimer's patient, and also, and I almost said in particular, but definitely on the lives of the immediate caretakers and their families. So it's very important to allow the early diagnosis, to allow effective preparation by the patient, him or herself, while they still have significant cognitive and executive functions. So there should be some family and patient counseling, some lifestyle modification. We know that, for example, aerobic exercise and good diet does improve, or does at least preserve some cognitive functions. Then, of course, obviously control chronic disease, as we mentioned, and start treating the disease early and alleviate some of those cognitive deficits. Early planning for the future. Important to do this gradually, not to overwhelm the patient or the family. I'm sure Dr. Georigiadou and Dr. Steele will speak very, very well and very much in depth on these topics. And of course, there are often subtle cognitive impairments that can often go undiagnosed, and it should be careful because there are some studies that show that perhaps some your African American Hispanic patients might be going underdiagnosed in terms of Alzheimer's. Primary treatment of Alzheimer's, non-pharmacological, of course. Care planning, extremely important. Coordination of care, both clinical specialists and, of course, most importantly, community support services. And as I said, this will be explained in much better detail by the speakers coming up. Care planning, of course, while the patient is still able to understand and communicate effectively, that's the best time to do this. You want to be sure that the quality of life is preserved to the most possible, that there are significant assessments on a regular basis to be sure to get an idea how fast this is advancing, behavioral assessments, discussion medications, and of course, eventually terminal care planning with the patient and, with the family, because this is a deadly disease. Primary treatment for Alzheimer's, there's 4, 5, 6 medications, perhaps a few more that come out. Most of it is concentrated on the use of cholinesterase inhibitors to break down the enzyme that actually breaks down acetylcholine, and this prevent, and because the Alzheimer's is characterized by losing neurons that actually secrete acetylcholine, a neurotransmitter that is very important for brain function. So most of these are cholinesterase inhibitors. Some, like donepezil, widely used. Others are less used. I remember tacrine was very commonly used. Now it's rarely used now, I believe. And then there's medications like namantadine for more moderate, severe Alzheimer's disease. People who are beginning to treat or treating people with Alzheimer's, of course, are very familiar with medications, the side effects, because unfortunately many of the side effects of these medications sometimes mimic the disease itself, so it can be tricky. And of course, the management of, along with this, of depression, which is very important. Now, I'm going to just briefly touch upon the caregiver, a very important element in this spectrum of Alzheimer's. There's estimated that over 15 million people are actually providing caring care for people with Alzheimer's. Who are these caregivers? They're usually older folks, and they're usually female. Although, interestingly enough, Alzheimer's affects mostly females, and yet again, the care of the Alzheimer's patients usually in our culture at least is left to females, the wife, the daughters. The largest number of caretakers are, of course, the spouses of patients. Then come, the daughters. We call them the Sanders generation, because they have to take care of their parents, and at the same time they have to take care of their children, of their families, and you can just already see the building of a stress in these folks. A very important element of the Alzheimer's spectrum. And of course, some, let's not forget, many Alzheimer's patients do live alone, actually, and they are under the care of friends and neighbors and just the goodwill of other people. So not everybody has a good support system. For the caregiver, Alzheimer's represents a very significant burden emotionally, financially. Many have to quit their jobs or take on the part-time jobs. Second, they have to, secure the home, make it safer, buy locks, take all kinds of precautions so that the Alzheimer's patient won't just now walk away. They have to secure the kitchen. They have to secure all these chemicals, secure the car. There's also physical burdens. It gets to a point you have to actually lift the patient, guide the patient. Sometimes they get, anxious, maybe a little violent, and this and that. So it takes a tremendous toll on caregivers. As I said, this will be explored in greater depth. And then you have to look, of course, for the health of the caregiver. They're very, very vulnerable to physical, emotional, financial stress. Physical, because many times they have to get up in the middle of the night. They don't get good sleep. They don't get good rest during the weekends. Emotional. It's very difficult to deal with a loved one that's just degenerating, who doesn't recognize you, who gets attacks of anger or emotions. That for the caregiver, it's an emotional roller coaster that they have to deal with. And of course, very important, extremely important to provide strong support to caregivers, because they are essentially the folks who are going to be taking care of the Alzheimer's patient for all the years until they're institutionalized. Care planning, of course, obviously, as soon as the patient is diagnosed with Alzheimer's, to evaluate the understanding of Alzheimer's, dementia, make sure that the caregiver understands what the disease is, how is it going to progress, what kind of a toll is it going to take on both the patient and themselves, and of course then referral to resources. There are many resources there available for the caregiver, for the Alzheimer's patient, but people have to know about them and know how to access them. And of course, the clinicians taking care of the patient have to evaluate what kind of support system both the patient and the caregivers have in terms of other family members, other friends that can help them, give them strategies to cope with stress, for cope them with depression, and protect them from actually being involved in an abusive situation, mostly brought about by the stress of taking care of an Alzheimer's patient. Caregiver training, very important. Of course, helping them keep a log for Alzheimer's patients. And all of these are strategies that I'm sure will be explored. In my search, I found one a while ago, a slide by Dr. Manson that talks about coping with difficult behaviors. I found it interesting, and you may wish to explore. Grants and funding, and I'm coming now towards the end of my talk. The biggest funder, of course, is the federal government. And if you go to grants.gov, you have access to all these grants available from the National Institute of Health, Center for Disease Control Prevention, Food and Drug Administration, Agency of Healthcare Quality and Research. Grants.gov just gives you a tremendous resource that you can search by agency or by type of grant. And there's currently some grants there for various, mostly research in the area of Alzheimer's, not just research of patient, but also caregiver situations. I also find a little site called Grants Watch that has some grants, not terribly large, but mostly for providers and for academicians. Of course, the Alzheimer's Foundation, and once again, the other speakers will have a bit more developed this section also. Well, thank you so much. I've gone through it terribly fast. It's a very important disease, very complicated, and something that it's just going to grow. Primary care providers will see a tremendous growth in their patient population with Alzheimer's dementia as the older population, as the baby boomer population gets older. But once again, thank you so much, and don't let me take more time from Dr. Georigiadou and Dr. Tilly.
Thank you, Dr. Pacheco. I will touch on certain aspects of how to approach a caregiver as a healthcare provider, and you kind of touched on that already, so I will go in a little more depth. All right, so I will talk about the signs and the symptoms of an overburdened caregiver, talk a little bit about the family system dynamics in the caregiver and dementia patient dyads, and then I'm going to talk some more about how to approach caregivers and address issues like their responsibilities and their limitations, the relationship with the dementia patient, and how previous experiences with that person may be affecting the way they care about them currently, and how to give them some resources so they can handle the demands of care more effectively. Oops. Dr. Pacheco already mentioned, the different aspects, the different burdens of family caregiving, limited time, and having to figure out, a daily schedule and a routine for the dementia patient, physical burden for the caregiver, and financial costs and emotional burnout are also very important to take note of, and physical health risks as well for the caregivers. Some signs that a caregiver that show that a caregiver is getting burned out. Often we see caregivers report that they have been missing their physician appointments, they have been ignoring their own health problems, they have been overeating, a lot of emotional overeating, gaining a lot of weight, or not eating a healthy diet because they don't have time to cook and prepare healthy meals for themselves, overusing of overusing cigarettes and alcohol when they get stressed, giving up exercise. They may report sleeping problems, mostly because of the caregiving process, waking up at night or not being able to sleep enough usually. And then it's important to note if the caregivers have been socially and not staying in touch with friends, so that they're able to use that as an outlet for themselves. And number one indication of an emotional burnout for me as a therapist is when I observe a caregiver holding in feelings of anger and frustration, and then almost being surprised at themselves because of outbursts that they have, whether that's towards the dementia patient or other family members, co-workers, or even strangers. Other signs that indicate an emotional burnout for the caregiver is any reports of feelings of sadness, feeling hopeless or helpless, reporting a great loss of energy, fatigue, lacking interest in things that used to give them pleasure, expressing resentment about the dementia patient, and feeling that others ask more of them than they should, feeling like feeling that their family relationships are suffering because of the caregiving role, and getting irritated at other family members who don't help as much or not at all, and might criticize their care, and getting upset by arguments with others about their situation. Many times, of course, because I treat the family as a system, I see a lot of reactions from the family members that are not taking care of the dementia patient, stepping in only to ask the caregiver, why don't you do something different, or why don't you try such and such, and that can create a lot of added pressure for the caregiver. They are not receiving any actual help, but they have a lot of other family members offering their opinions about how the dementia patient should be taken care of. So again, from activities, or they want to be more independent. And it's hard for the caregiver to distinguish the level of competency for the dementia patient, and that's where the healthcare provider, the physician, the PCP can offer their professional advice and insight for the caregiver, so they can help the dementia patients be involved in small tasks, or allowing them to do certain things by themselves under supervision, but still give them the freedom to do certain things, even little things, for themselves. And then it's important also for the healthcare provider to look for what the particular needs of each patient and each caregiver are. So, for example, research shows that caregivers for cognitively demented patients might benefit more from emotional support, while caregivers for demented and frail patients might be more concerned with knowledge of nursing skills. So these are two different sets of skills and two different types of support that a physician can offer, or a healthcare provider can offer to the caregiver. again, from a therapeutic standpoint, I always try to make sure that I normalize the range of emotions and the turbulence that dementia can bring into a family system. It's a relational issue. It's not a one-person problem. And I always allow the caregivers to express their feelings and what meanings they might attach to their caregiving role. Some of them might be readily available to step into that role, despite the challenges, that this entails, because they feel, a sense of paying back, being faithful and loyal to the dementia patient, especially if the dementia patient is a parent. In some other cases, it can be more matter of duty. The caregiver might feel extreme guilt and a sense of obligation, so that will be the reason why they take on that responsibility. It's also important to address the isolation that a caregiver might feel, especially if the dementia patient is a spouse. The distorted communication and the maybe the lack of communication with the spouse who is a dementia patient and not able to communicate as well as before. It's very important to address. That actually has, I think they call it in the literature, anticipatory grief. It's a different kind of grief. It's not grief for the death of a loved one, but it's grief over the death of the relationship as it used to be. And so it's essential that is not able to take care of themselves and be independent as they used to be. So that's a real challenge.
Welcome to GoToWebinar, Web Events Made Easy.
The grandchildren, how their relationships are changing with grandparents, and can I help them make sense out of why grandpa can't understand everything that you say, or why grandpa can't take you to the park by themselves, or things of that nature. So there's a lot of the pressure and responsibilities in that sense for the caregiver. And again, as I said, processing the grief in anticipation of the loss of the dementia patient. And there's, for that particular issue, it's important as healthcare providers that we make sure all family members and the caregiver know that they do not have to grieve the same way. They might, some might be more focused on specific problems and more task focused, and that's their way of grieving, and other family members might be more emotion focused and in need of support services or a support group where they can that they can use as an outlet. So not each family member has to grieve the same, but it's important that the family will come together to grieve together and kind of create some meanings out of, you know, what happened to their family and what good they can make out of this situation, how they can remember and honor the dementia patient, remember past experiences they had with them, and kind of maybe have closure in case there was abuse or abandonment or some other traumatic experience. So from a therapist perspective, reframing can be more important than actually you know, referring someone to a social support group or providing, you know, group therapy or something of that nature. Helping actually giving the caregiver some food for thought, as I like to tell my clients, to kind of think about how has this event, this disease changed their lives, and how they can commemorate and honor their loved one, what they can what they can do different in their lives as a result of that experience going through the caregiving role, and maybe how they can pass on the dementia patient's life work and their honor their place in the family. So caregivers do need a lot of intensive, you know, skills training and assistance with problem solving. Sometimes they're not as familiar with the dementia symptoms and how to deal with those. So they do need more information regarding, you know, the specific diagnosis and how they can tackle certain behavioral symptoms. Research shows that caregivers that are more firm and directive with the dementia patient tend to have less depression. So again, it's important that you address how the dementia patient can be involved in simple household tasks, and how the caregiver can be more firm and directive with them. So for example, if let's say the dementia patient keeps asking, you know, where is John? Where is John? Where is he? Where is John? A anger outburst would be a very different reaction from, you know, Mom, John is not here, so let's get things ready for lunch, because he's going to be here by then. Some response of that nature would be more firm and directive than, you know, getting exasperated and lashing out at the dementia patient because of their repetitiveness. Okay, I think I kind of touched on the family dynamics. Some things that I wanted to make a note of, again from a systemic perspective, is as healthcare providers, you're more likely to notice a lot of resistance to change on behalf of the family. It will be, dementia is a real hard blow for the family structure. Sometimes the family members have to completely reorganize their lives around the dementia patient. And what you notice then is that often the family members are in denial because it's too frightening and hurtful to even acknowledge that a family member has dementia. They may feel inadequate or unsure about how they can be a good caregiver for that person. They may be uncomfortable with stepping in and making decisions for them. Or they may resent having to take on all that responsibility because maybe their relationship was completely non-existent before. There was maybe abuse or an emotional cutoff from the family. And even the dementia patient themselves, they might not have the insight to acknowledge that they can't be completely independent as they used to, and that lack of control over their lives can make them real resistant to any type of care. Or they might be completely unaware that they have memory problems, or they might be scared or embarrassed to acknowledge that they have memory problems, or they can't take care of themselves, they can't use the bathroom by themselves, they can't drive anymore. Things of that nature. And it's important that as healthcare providers we normalize that this process for the caregivers it can be an emotional roller coaster. It can have ups and downs, and you might, as a caregiver, you might go through cycles of grieving, anticipatory grieving, and feeling more hopeful, or maybe making sense out of this, making something good, create some new meaning out of the caregiving process. So as a caregiver, what are your strategies for stress relief? That's a good question for a physician or a healthcare provider to ask the caregiver. If they cannot provide an answer, then that's an area of concern. Research shows that caregivers who use more problem-focused strategies have less stress, actually. So as a healthcare provider, when you ask a question like, when something goes wrong with your brother's care, how do you react? An emotion-focused response would be, I would cry, or I would put him in a home, a nursing home. A problem-focused response would be, I would call the doctor and find out why that is happening and how I can deal with it. So a tendency to use emotion-focused responses should alert the healthcare provider to an increased risk of burnout in the caregiver. So caregivers in literature are the hidden patients. They're the ones that maybe healthcare providers do not necessarily focus on, but they need as much care as the dementia patient, only of help from different resources. Let me see. I think I already talked about how important it is that healthcare providers, whether that's a social worker, a physician, or someone else, that they discuss the nature of the symptoms of dementia with the caregiver. They educate them, and they address the challenges ahead and the possible resistance from the family to change, and also discuss with the caregivers, their limits, how much they can do. That will help them recognize in themselves when they start getting burned out. So loneliness or isolation are two of the main burdens for caregivers. Support groups for caregivers are available, and also there's a lot of adult day services for dementia patients, which can give a little break for caregivers to take care of other responsibilities, take care of their own family and children. a little note for the transition of the family to bereavement. And I think I already kind of talked about that, but research shows that the caregivers who feel more burdened and burned out from their caregiving responsibilities tend to have more difficulty with the bereavement process after the dementia patient passes away. So it's very, very important that healthcare providers help prepare the overburdened caregivers for the emotional challenges ahead, and really ask them to step in and take care of themselves before the challenge actually is there. And again, studies show that when discussing hospice options and care, the most important features of hospice for the caregivers were continued follow-up evaluation, so collaboration of the patient's primary care provider with the hospice center, and the hospice emphasis on helping patients to avoid admission to a hospital. So for healthcare providers, there's 5 areas of opportunity to intervene and help caregivers of dementia patients: promoting the communication with the family, encouraging care planning and supporting home care, and really making sure that demonstrating empathy for all the emotions and the change of the relationships in the family, and then also addressing family grief and bereavement issues. Some final thoughts on my end. Wrapping this up, I think I addressed mostly everything on this page. As a systemic therapist, I'm always thinking about what language I use to describe and talk about my clients. So you'll find that the way you describe your patients will affect how you address certain issues with them. So are they victims? Are they troopers? Are they helpers? Are they, people with supernatural abilities? The language that we use as healthcare providers affects how we address certain situations with the dementia patients and the caregiver. And it's important to make sure that the caregiver also has either people or groups or agencies in place that are taking care of them, not the dementia patient. Yes, and through this process, I think any healthcare provider also finds greater meaning in their own work by helping the caregivers of dementia patients cope with all the symptoms and the changes in the relationships that this disease creates in families. And that's the end of my presentation.
Good afternoon and good morning, everyone. This is Jane Tilley. I'm still trying, my computer's a little bit slow in pulling the slides up. I realize we've gone over our time for a little bit, so what I'm going to do is move fairly quickly through the slides and basically provide you with some very basic information and encourage you to contact me. My contact information is on the last slide in my presentation, and encourage you to contact me with any questions that you may have that I'm not able to address. So for some reason my slides are not coming up the way they should. I apologize for that. So I'm just going to start clicking through this in the interest of time. Actually, I'm so sorry. It looks like my computer has frozen. I'm so sorry. I don't quite know what's going on technologically, but anyway, the learning objectives, these slides will be available later on. When the learning objectives for this are to understand the care options that are out there for persons with dementia, to learn about tools and resources to help them, and okay. I'm going to be talking about care options, tools and resources for people with dementia, and opportunities to participate in research studies. The care options that are available relate to the Older Americans Act programs, to Medicaid, to Veterans Affairs, and to state-funded care options. There, let's see, maybe this will work now. All right, sorry about that. And also to ways people can use their private funds. In thinking about care options, the Older Americans Act program provides a wide range of services, including home and community-based services and services targeted to caregivers. It's important to know about the Medicaid program in your state. Medicaid covers, in most states, covers home and community-based services for people with dementia. There are income and asset tests associated with that, as well as the Medicaid nursing home coverage. Veterans, but it's important that you know what's going on in your state because the state rules vary across the country. Veterans Affairs for veterans who meet certain eligibility criteria, have home and community-based services available. For example, they have a home-based care allowance that's been in place since, I believe, the 1980s. They also cover nursing home coverage, cover care in nursing homes. And then many states have care options that they fund using strictly their own funds that fill in the gaps, for example, in Medicaid and the Older Americans Act. And those families with sufficient means can use their own funds to access dementia-capable services. I'm going to spend most of my time talking about services available through the Aging Network. The Aging Network is led by the Administration on Aging, which has a central office where I work and regional offices. Each state has a state unit on aging. There are over 600 local area agencies on aging that receive funding from their state units. The state units receive funding from the Administration on Aging. And then there are over 20,000 local services providers. And we also have tribal organizations that we help fund. Okay, it looks like my screen is frozen again. I'm not quite sure what's happening with this. Can someone help me fix this? Okay, I'm still kind of frozen here.
Hi, Jane.
Yeah.
Devin has your slides on
He has my
his
slides
computer. Yeah, and we'll
Okay.
just, on our end, and just let us know when you're ready to go to the next slide, and we'll just advance the slides for you.
Okay, if you could go to the next slide now, that would be good. Okay, I'm going to run very quickly through the services that the Aging Network provides. One, it's very important to understand is that there's information and assistance available through the area agencies on aging, and every area agency on aging has that kind of assistance. There's also outreach and transportation available, as well as case management. The level of services varies from local area to local area. Next slide, please. There are elder rights services that involves the long-term care ombudsman, elder abuse prevention, benefits, pension and counseling, and legal assistance. Community services are available, such as care and adult daycare, senior centers, employment services, health promotion, and disease prevention. Next slide, please. And then there's an array of in-home services that can be available through the Aging Network. And the best local access point, of course, is the Area Agency on Aging. The eligibility for these services is generally age 60 and over. It's important to note that unlike Medicaid, Older Americans Act programs do not have income or asset requirements, nor do people have to be citizens to get these services. However, the services are targeted to those with the greatest economic and social need. Caregivers can get services, people who are aged 18 and over who are caring for someone who's aged 60 and over, or persons with dementia of any age. Grandparents and other non-parent relatives can also get caregiver services. And the biggest source of caregiver funding is through our National Family Caregiver Support Program. Next slide, please. I'm going to be talking about tools and resources next, if you could advance the slides. Here are some resources that are funded by the Administration on Aging, which is part of the new Administration for Community Living. You can see the ACL acronym there at the top. We have a National Alzheimer's Call Center that we've funded, run through the Alzheimer's Association, and that 800 number is listed there. People can get assistance 24 hours a day, 7 days a week. There is a new Alzheimer's website for caregivers called alzheimers.gov. We also have a resource page at AOA, and we also have grants that are targeted to people with Alzheimer's disease. Next slide. This is a slide talking about the capabilities of the 24/7 National Contact Center. People answer those calls, as I mentioned, continuously. There are general information specialists who answer general questions, and then there are master's prepared care consultants who can answer questions that people might have about more than just wanting general information about Alzheimer's disease. Next slide. Alzheimers.gov, this is a screenshot. This is the new website that I talked to you about that is targeted to caregivers. You can see that there's general info. If you look across the top, those bars there in blue, there's information about Alzheimer's disease in general, treatment options, planning for care, and getting help with Alzheimer's disease and fighting the disease. Next slide. So I'd encourage you to visit that. We also, in the AOA Resource Center that I mentioned earlier, we have a number of webinar series that are accessible for anyone who wants to access them. We have one on legal issues in Alzheimer's disease and another that talks about Alzheimer's disease and tools for caregivers to use. And you can see the third bullet is where you would find those resources on the webinars and other types. Next slide. The Alzheimer's Disease Supportive Services Program is a competitive grant process that AOA has been running for, I believe, about 10 years. And the purpose is to deliver supportive services to people with Alzheimer's disease and their caregivers. And one of the major ways in which we do that is to translate evidence-based models, that is, interventions that have been tested in randomized controlled trials. We translate them into community settings and test whether or not the results are consistent with the original intervention. We also have grants related to dementia capability, and those grants are encouraging state, home and community-based services systems to be able to identify people with dementia, make sure their staffs are trained to help those people and their caregivers with their special needs, and refer them to care providers who know how to deal with the special conditions associated with dementia, in particular some of the behavioral symptoms that Dr. Pacheco talked about earlier. And the way to find out about where those programs are is at the website that I've listed. These grants are not available across in every state, but many states do have them, 30 states, DC, and Puerto Rico. Next slide. And then another thing to look at is the Elder Care Locator. This is, again, something that is funded by AOA, and you can see from the screenshot that you can either go to the website and search by topic, one of the topics being Alzheimer's disease, or you can call that 800 number and get connected to local resources. Next slide. I mentioned some of the resources available at that Elder Locator website already. We can go on to the next slide, please. And then the final thing I was asked to talk about are research opportunities, so if we could go to the next slide. This just is a graphic showing everybody that needs to be involved in research, and I think that's kind of self-explanatory. We'll go on to the next slide. And so there are a number of different ways to get connected to research trials that are going on right now. They're through the first three bulleted programs are funded by the National Institute of Aging, and that is part of the National Institutes of Health. And the final bullet, Trial Match, is funded by the Alzheimer's Association. So we're going to go next to and talk about the Alzheimer's disease centers. These centers, you can see from the map, they're located in many parts of the country, but not everywhere. They conduct research on all aspects of Alzheimer's disease, and importantly, when a person can't get a diagnosis from their care provider, maybe their routine care provider, they can go to these specialized clinics and get a diagnosis and education there. And also these centers conduct research trials, so there are opportunities to participate in research through these Alzheimer's disease centers. Next slide, please. The National Institute on Aging also funds the Alzheimer's Disease Education and Referral Centers. These encompass the research centers I just talked about. This center provides information about clinical trials, new research findings, basic information about Alzheimer's. It's important to know that you can sign up for alerts and get free publications from this website. Next slide. And there is a function at the Alzheimer's Disease Education and Referral Centers where you can search for clinical trials by location, eligibility criteria, and the types of drugs being tested. There's also an 800 number that people can call to find out about trials, and there's also the ability to sign up for alerts. The next slide, please. The Alzheimer's Disease Information Network educates the public about research, and there's a website you can see there. Next slide. And finally, there's the Alzheimer's Association Trial Match, which is designed to increase the number of people enrolled in Alzheimer's trials and studies and provide information to the public. Next slide. I guess that must be, I'm surprised that it appears that's the final slide. The trial match also has an 800 number and a website that can help people figure out which which research trials they might be able to participate in. And then the final slide in this series did have my contact information, which I'll just give you my email address if you want any more information about the Aging Network, what we have available through AOA, and in terms of services, as well as any of the information that we've been able to talk to you about clinical trials. My email address is jane.tilley@aoa.hhs.gov. Again, that's jane.tilley, T-I-L-L-Y, @aoa.hhs.gov. I'm sorry about the technical difficulties. I'm not quite sure what the reasons for them are, but my apologies for the awkwardness of this. And I believe I can turn this back over to the moderator.
Thank you very much, Dr. Henry Pacheco, Dr. Sophia Georigiadou, and Dr. Jane Tilley. We really appreciate you presenting today's webinar for Alzheimer's, providing knowledge and care. We rely on experts like yourself to bring valuable knowledge to our Aging Health Center grantees and to anyone that wants to listen to the webinar and find knowledge from the topics that you have presented. We are now going into our question and answer session, so please, if anyone has a question, you can type it into the question box, or you can hit the icon that has the raise the hand, and you will be unmuted, and you can ask a question through your telephone or microphone. While we're waiting, let's see. This is for Dr. Tilley. Question came through. Has AOA or ACL developed any recommendations or ways to alleviate pressures on the caregiver workforce, and such as training people and adding caregivers to the workforce to provide more respite care?
We do have training that we have funded under the Alzheimer's Disease Supportive Services Program, which has in fact provided training to both state and local staff who deal with people with dementia and their caregivers, as well as providers of those services. This is not across the country, but we have dementia capability grants out in a number of states. And so, for example, in Massachusetts, that state has trained people through their Alzheimer's disease Aging and Disability Resource Centers, and have done dementia capability training throughout their home and community-based services system.
Okay, great. I think that was really the only question that came through. The presentation was phenomenal. This is a subject that needs to be discussed more across the whole healthcare system. And at North American Management, we truly appreciate the panelists speaking today and taking time out of their busy schedule to present. And I would like to announce that we are having our national conference for the 2013 Health Centers and Public Housing National Symposium. That will be in Denver, Colorado, June 4th through June 6th. And you can come and participate in training events that will focus on keys to successful health centers. Please submit your call for abstracts by January 7th, and we will also send out information regarding our National Aging Symposium that will be happening next in 2013 as well. Once again, we thank you to the panelists, and we thank you to the attendees. Have a happy holiday and a safe and happy new year.